Today we're going to talk about drugs of abuse. And just leading off into drug abuse, there are a lot of social stigma. There's a lot of political perspective on just the word, the term drug abuse. And drug abuse itself is both medical and psychological. And, we can abuse anything. So, drugs of abuse that we're going to be talking about is any drug. It is legal or illegal as long as it's used in some harmful way, inappropriate way, irresponsible way. We are abusing that drug, we are abusing that substance. And with that, we'll go through some basic terminology and just define a few terms: addiction, dependence, and tolerance. These all go into our drugs of abuse and drug abuse. First, addiction. We've got the 5 C's of addiction. So, kind of what keys us into, what tells us, what leads us to addiction. One is chronicity. So, maybe, I'm abusing caffeine and I do it chronically. I do it every single day. Um, I've got compulsive use, so not only every single day, but multiple times per day. I just do it. I have to do it because I'm craving. It's our third C. I'm craving it. I need that caffeine. Um, I've got impaired control is our fourth C. Kind of throwing the control in there as the C. Impaired control over my drug use. I just I have to have it. I need it. And I've got continued use despite known harm. Maybe I know, I'm throwing PVCs all the time. I've got insomnia. I can't sleep. I'm jittery. I'm on edge. But I continue to use this caffeine despite the known physical harms to me. I just have to use it. I use it every day. I use it multiple times a day. I crave it when I get up in the morning. I crave it in the afternoon. And I just can't control it. For dependence, we have psychological dependence and physical dependence. Sometimes they go hand in hand, sometimes you have one without the other. So psychological dependence is I'm taking this drug for stimulation purposes. It's stimulating some pleasure center. It's giving me this like, positive feedback, this positive reinforcement. I drink coffee, I take in this caffeine, and it makes me feel energized. Well, that's positive reinforcement. So I've got this psychological dependence on this drug that, okay, I need stimulation. I need to feel energized. What do? I drink coffee. So that's psychological dependence. Physical dependence is if I don't take in that substance, that caffeine, then I have withdrawal symptoms. That's a negative reinforcement. So I've got positive reinforcement on the psychological side. I've got negative reinforcement on the physical side. If I don't have that cup of coffee in the morning, I feel terrible. I cannot get going. You can't really fully function before having your cup of coffee. And then our last term that we're going to just quickly define is tolerance. So our drug tolerance. Over time, we need higher doses to achieve a similar effect. So I just started drinking coffee, and 1 cup of coffee does a lot for me. As time progresses, maybe a few years go by. Well, now that first cup of coffee doesn't really do a whole lot for me. I need a second cup or a third cup just to kind of get going. So I need higher doses as my body gets tolerant to that substance. This is not necessarily correlated with dependence, but it could be that all three, addiction, dependence, and tolerance, could go together, but we can have one without the other. And so tolerance just speaks to the dose required to achieve the effect that we want. All right, let's highlight a handful of commonly abused drugs that we see in emergency medicine. We'll start with CNS depressants, central nervous system depressants. The biggest of which is alcohol. So the number one abused or substance abuse problem, I should say. This is ethanol. This is our drinking alcohol, ethyl alcohol, and alcohol produces very similar effects as benzodiazepines. Goes after your GABA receptors. So alcohol very commonly abused and is a CNS depressant. Then we have barbiturates. Barbiturates were and still are a little bit marketed and prescribed as sleeping pills. So we can prescribe and abuse phenobarbital. So phenobarbital is one of the more common barbiturates out there. Again, going after those GABA receptors. So when these were being prescribed as sleeping aids, we can abuse prescription medications as well as over-the-counter drugs like alcohol. So phenobarbital and barbiturates are also CNS depressants. And similarly, if you've ever heard the term roofie, that is Rohypnol. And Rohypnol is a benzodiazepine. It's a very potent benzo. 2 milligrams of Rohypnol is about equal to, give or take, 20 milligrams of Valium. So that's a lot of Valium. So it's a very potent benzo. Rohypnol produces drowsiness, impaired motor skills, amnesia. So if you've ever heard of roofies or the quote-unquote date rape drug, that's what this is. A very, very, very potent central nervous system depressant. And any discussion of CNS depressants would be incomplete without talking about opioids. These opioids, well, they stimulate opioid receptors and dull pain, relieve anxiety, give you feelings of euphoria, are very commonly abused. And what we're going to see some flushing of the skin. Patient might say they kind of have a heavy feeling of their limbs, kind of harder to move, slower reaction times, right? CNS depressants were slowing everything down. And if you look at the pupils, we're going to see constricted pupils, smaller pupils. And if someone is physically dependent on opioids and we take them off these opioids, whether suddenly or chronically, we're going to run into some withdrawal issues, muscle pain, bone pain, which is sounds odd, but which is very, very, very painful and like the deep, deep pain. You're going to suffer from insomnia, maybe vomiting, diarrhea, cold flashes, even into seizures. So, something to discuss when we talk about giving Narcan, naloxone to a chronically, physically dependent opioid abuser. Opioid drugs are both legal and illegal in the United States. So we can abuse our prescription, our legal opioids. You'll see fentanyl, you'll see codeine, all of our oxycodones, hydrocodones, Demerol, and Dilaudids. These are all prescription medications. These are all legal medications that are commonly abused. On the illegal side, we have heroin, which is highly addictive. It is processed from a morphine type concoction. It has a very immediate effect. The danger here, amongst other things, a big danger here, the varying potency. So it's an illegal drug, a legal substance, and so it's not controlled. It is not regulated. So someone taking it doesn't know the potency of that dose that they're taking. So even the most seasoned of heroin users can easily overdose themselves because they just get a batch that is a little bit more potent, or even much more potent than they're used to. So heroin is illegal, is one of the illegal opiates, and a big concern here is the varying potency for these users. All right, moving from central nervous system depressants, let's go over to the stimulant side and talk about first amphetamines. And amphetamines are chemically similar to adrenaline and will really stimulate you. There are legal medical indications for amphetamines. ADD and ADHD are prime examples of that. Also, narcolepsy, to keep you awake, we're going to give you an amphetamine, and obesity to try to stimulate the metabolism and get you to lose some weight. Just metabolically, we can give you this stimulant. So Adderall is one of those legal amphetamines used for ADD, ADHD, and methamphetamine is one of those illegal amphetamines. So let's focus on methamphetamine for a moment, one of those illegal CNS stimulants. It is highly, highly addictive. Very highly addictive stimulant. It can be smoked, snorted, injected, taken orally, just every way, shape, and form you can take in methamphetamine, and it dramatically affects the brain. It hits the brain hard. It really affects your wakefulness, your alertness. People will take methamphetamine and be up for days. You have feelings of increased strength and energy, and just it's a stimulant. It's a central nervous system stimulant, a very potent stimulant. Dangers here, you have feelings of invulnerability, dangers for the user and dangers for the provider tending to the user. They feel invulnerable. And they have these feelings of increased confidence and competence. So they can do anything, nothing bad will ever happen to them. They've got feelings of paranoia thrown in there, so be mindful of this when you're dealing with your patient who has recently used methamphetamine. Longer term effects of methamphetamine goes into depression. So we've got this exogenous stimulant, so the brain stops and the body stops producing its own kind of stimulants and says, okay, so when you stop taking it, or you become dependent on it, physically or psychologically, right, we go into depression because now we need this methamphetamine to bolster our mood. Methamphetamine users, chronic methamphetamine users, usually typically have a binge and crash pattern of use of the drug. They'll take it. They'll be on methamphetamine for a day, for 2 days, for 3 days, and just binge. And they're up for 2 days or 3 days, and then they crash, and they crash hard when they stop using it. And methamphetamine causes pretty significant brain damage, even on the first use. So if you've never used methamphetamine and you just use a little bit, you feel really good, it can cause some pretty significant brain damage there. And that eventually leads to very, very significant paranoia as well. So as the chronic user continues to use methamphetamine, you'll see a lot of paranoia and potential really kind of almost hallucinations. On our end, on the emergency medicine end, what are we going to do for methamphetamine, or really any amphetamine overdose? We're going to go after that stimulant with a kind of a depressant. We're going to go with propranolol. Is a good medication to use for these patients. It's a beta blocker, and it's going to kind of slow everything down. So if we've got a patient took an amphetamine and blood pressure is through the roof, heart rate is through the roof, well, we can give a beta blocker to kind of slow all of that down and curb all of that. For a methamphetamine user, we might need to use Haldol, haloperidol, or dopamine blocker. So we've got runaway stimulation in the central nervous system. We can give this haloperidol to block that stimulation. Another CNS stimulant is cocaine, extracted from the coca plant. And just as a reminder, it is a Schedule 2 medication. It is not a Schedule 1, it is a Schedule 2. There are medical indications for the medical use of cocaine. So that's your little bar trivia for the night. Is cocaine is a Schedule 2 drug, and some effects of cocaine use itself. We increase energy. It's a CNS stimulant. Of course, we increase energy, decrease appetite, effects on mental alertness, increases in heart rate and blood pressure. Our pupils will dilate, our blood vessels will constrict. Long-term cocaine use, obvious addiction, leading to irritability, mood disturbances. Our body chemical composition is changing, running into issues of paranoia, restlessness, and even hallucinations. For EMS providers and paramedics, we're going to be called out for cocaine users because there are some complications here. There might be some acute complications. Cocaine users can have heart attacks, can have strokes, they might have chest pain, shortness of breath, abdominal pains, and nausea. So, why would a cocaine user have a heart attack or a stroke? Well, if we go back, we have constricted blood vessels. So, if I happen to constrict my coronary arteries, if I happen to constrict my cerebral vascular system, I'm going to decrease blood flow, decrease oxygen supply to my heart, to my brain. So we can see cocaine users having heart attacks and strokes without without a clot. It's not a clot; it's vasospasm. It's constriction. Still decreased supply, decreased blood supply, decreased oxygen supply. But these patients are having heart attacks, are having strokes. So that's what we're going to see, or might see, in the EMS and the pre-hospital environment. Then lastly, under our CNS stimulants, of course we have to talk about caffeine. Just about everyone has taken caffeine at some point in their life. Is the most widely ingested drug. So teas and coffees and sodas, these all have caffeine in them. There are medical uses for caffeine. We can treat apnea. So neonates, just freshly born little babies. Neonates we can you might see in the hospital in NICUs are treated with a little bit of caffeine to treat apnea and narcolepsy and fatigue. We can medically treat with caffeine. Okay, let's talk just a couple more like miscellaneous drugs of abuse. We've got hallucinogens like LSD, and these medications here, like LSD, activate and like hyperactivate our serotonin receptors. They cause hallucinations. These hallucinations, and typically we think of hallucinations as visual, but they can be visual hallucinations where we see things that aren't there. They can be auditory hallucinations where we're hearing things that aren't there. They can also be tactile hallucinations. So I'm feeling things. I'm like hyper feeling, or I'm feeling something that isn't there. I'm touching a brick wall, but it feels fuzzy, right? It feels like I'm petting my dog. Or I can have olfactory hallucinations where I'm smelling something. I I smell my phone and it smells like oranges. So we can have hallucinations across the spectrum of our senses. Then we have phencyclidine or PCP. PCP is angel dust, or it's got a number of other street names, but PCP is a dissociative drug, and what dissociative drugs do, medications just like ketamine and nitrous oxide are both dissociative medications as well. PCP and these dissociatives, they kind of disconnect you from you, kind of disconnect your sensing self from your thinking self. Um, you're there, but you're not really there. You're connected, but you're not really connected. So, PCP is affecting a number of neurotransmitters. If you have any questions, comments, concerns, or cuss words, please let us know.